IVF can be overwhelming, but it doesn't have to be. Dr. Mark Trolice shares how to reduce risks, manage stress, and take back control of your journey to parenthood. Next on DocStars.
Welcome to DocPod's DocStars.
Hello, everyone. I'm JJ, and thank you for joining us on DocStars here on the DocPod channel. Today, we are joined by Dr. Mark Trolice. He's a double board certified in reproductive endocrinology and infertility, as well as an OBGYN. He's also founder and medical director, the IVF Center in Winter Park, Florida, which I love, as we were just discussing, a beautiful area. That is a full-service reproductive medicine clinic. And he's also professor at UCF College of Medicine and author of the Fertility Doctor's Guide to Overcoming Infertility. Welcome back to the show, Dr. Trolice.
Thanks, JJ. Always a pleasure to be with you and looking forward to a very stimulating conversation.
Yeah, I'm looking forward to this because I did a lot of research on you before this particular interview, and I know you were with us before, which was fantastic. And I want to dive a little bit deeper into the IVF stuff, and I want to address kind of the most relevant IVF concerns that people have today. And obviously, while sharing your expertise in innovation, patient-centered care, and risk mitigation, which is fantastic. So let's get started. In your book, The Fertility Doctor's Guide to Overcoming Infertility, you really focus on helping people discover their reproductive potential and also maximize their chances of having a baby. That's kind of my thesis of looking through that book. Do you see that as the kind of the core purpose of IVF? And if not, what am I missing?
Well, IVF is the most aggressive and successful option, but is also the most costly and invasive. So I think a good reproductive endocrinology and infertility specialist is going to go from the most conservative to the most aggressive. That's what we do in medicine all the time. First part is to diagnose. Why is this happening? Is this male factor, which is about 30% of the time? Is it female factor, about 40% of the time? Is there a combination? Or the dreaded unexplained, which is about 20% of the time. In talking in your question, what most couples, in particular the women, when they come to see me, are most worried about is me telling them you're never going to be able to have a child. And that's really unusual. I always provide options in the best or worst prognoses patients, and there are always ways to build your family. So I don't remember ever telling somebody that they could never be able to have a child, but it may not be the way that they originally wanted.
Yeah, of course. And that's really interesting because, you know, that's an area I want to kind of go a little deeper on. And again, as a former kind of president of the Florida Society of Reproductive Endocrinology and Infertility, patient candidacy is often a really important part of that. And so it's one of the most popular questions people have in understanding IVF, really talking about patient candidacy or no?
Well, with exception, everybody can undergo IVF. A woman just needs her ovaries, even if she doesn't have a uterus, and she just needs one ovary. Even if she doesn't have a uterus, we could have a gestational carrier. So we need sperm, of course. The more eggs you get, it correlates with higher success rate with IVF. So really, as I mentioned, in point of fact, everybody is a candidate for IVF essentially, but there are pre-treatment screening that we employ to ensure that everybody is the optimal candidate for IVF, making sure the uterus is normal, making sure that there's adequate sperm, that there's no damage to the fallopian tubes that could impair implantation. Blocked swollen tubes can do that, and we would remove that surgically before, making sure the uterus is normal, that it doesn't need any repair intrauterine like scarring or polyps or fibroid tumor. So while everybody usually can be able to go to IVF, we don't want to cut any corners because we want to make sure everything is optimal when we get there.
Yeah, of course. And I'm very curious, who is the typical candidate? If you had to say, I'm looking at a demographic, it's a woman, it's this age, because a lot of us have no idea about this, but who is the typical candidate for someone who's getting IVF today for what you're doing?
Well, usually by the time they get to see us, they've been trying for several years. And unless there is a severe male factor where they have no sperm, and we go to the testes to get sperm that requires IVF, or the woman has no tubes, it is not a lot of diagnoses that accelerate right to IVF. The ideal candidate probably has undergone several cycles of intrauterine insemination or IUI. Certainly, they had the evaluation for adequate sperm, open fallopian tubes with either a hysterosalpingogram or some uh, saline contrast that can see under ultrasound for the fallopian tubes, and then to ensure she's ovulating. But by the time they get to IVF, it's really usually most patients are in their 30s. The best prognosis patients, ideally less than 35, but they can go as high as actually till menopause. But unfortunately, the accelerated loss of eggs in the late 30s and early 40s really puts a damper on the success rate. Women lose their eggs from the time they were born, and they go through accelerated losses as they get older. But men are not excused from the challenges of fertility, JJ. Men
It's true.
above age 40 to 45 have lower fertility, higher rates of miscarriage. Even birth defects, autism, and schizophrenia start increasing as a man gets older. So it behooves the couple for two reasons, really, to proceed in a directed manner toward their fertility. Is that the older they get, usually it's more challenging just to parent, right? But
Of
also,
course.
the longer they go, the more challenges of the prognosis as a woman gets older and as a man gets older.
Yeah, no, that makes a lot of sense. And I think that's important because a lot of people think this is a one-sided problem. And we're going to talk about that later in the show because I do want to dig a little deeper on that. But I want to continue with this because it's interesting. I've had friends who've had IVF. I'm in my early 50s, and I've had friends in their early 30s all the way up to their mid 40s. And I guess the big question for me is, when should they see a specialist? So maybe talk about that process. How do they know when it's time to see a specialist?
Perfect question, JJ. The American Society for Reproductive Medicine defines infertility as more than 1 year of attempted cycles of conception with no predisposing factors of the couple, like prior
Okay.
infertility, chemotherapy, radiation, tubal removal or surgery, or known male factor, things that would say, hey, we really should check this out before. So after 1 year, less than 35, evaluation is appropriate. Between 35 and 39, about 6 months, and then above 39, really 3 months. It doesn't mean that it could never happen naturally, but you expedite the evaluation as a woman gets older because of the age-related decline in fertility in a woman, and certainly as a man as well.
Yeah, of course. Obviously, I mean, it's more beneficial the older you get. Again, it's trickier. And again, we can talk about that as well. And after they do choose to do IVF or at least get information about it, how do they minimize risk? How do women deal with concerns about side effects and those types of things? Because when I was looking through your book, that's a interesting area that I think a lot of us, especially men, have no idea about, but even some women would be curious about.
Well, preparing for fertility in general should compel the couple to be as healthy as possible. Cigarette smoking is sabotage really for your fertility. Obviously, no excessive alcohol. Really, there's no safe amount of alcohol for a woman when she's pregnant, so it's really ideal to not even be drinking during attempts at conception, or certainly not after ovulation. Recreational drug use should also be avoided. So health is an important part of the fertility journey because the obesity epidemic in this country really can cause havoc during pregnancy, complications, miscarriage, birth defects, preterm, pregnancy-induced high blood pressure or diabetes. So
Hmm.
the better you are, the better the pregnancy is, and the better baby. Okay. The approach to IVF and what should be done as they're preparing for that is really excellent communication with your physician, understanding what is going on, ask a lot of questions, and ensure that you are fully aware and consented for the process. Because no procedure in medicine is without risk, IVF included. So, what are the risks involved? Well, medication wise, since we're giving stimulated injectable hormones that the
Mm.
brain typically makes for IVF, but sometimes we'll use tablets that trick the brain to make the brain respond better. So, side effects will be a little bit of nausea, breast tenderness, or bloatedness. Uh, the risks of the overstimulation essentially is called ovarian hyperstimulation syndrome, or OHSS. Fortunately, with the changes in the medication that we give patients, this is pretty rare now, thank God. We used to give a hormone called HCG, which is actually the hormone of pregnancy. And we give that to trigger the maturation of the eggs before egg retrieval. We still do, but it's in select patients, really those who have a lower response and are much lower risk of hyperstimulation syndrome. Now we give a medication called leuprolide acetate, which is really mimicking what the brain does naturally. And the risk of OHSS is still there, but very, very low. You'll get sporadically a patient that would probably in the much single digit percentages of getting hyperstimulation. Thankfully, there's risks of the egg retrieval. Egg retrieval is done typically under sedation in an office-based surgery center. So they get an IV and they experience conscious sedation. A needle is placed under ultrasound guidance through the vagina into the ovary. Tiny needle, and we vacuum out the cysts with eggs. Fluid comes out, drains the cysts, and the fluid is analyzed under the microscope to determine the eggs. It's a pretty quick procedure, 10, 15 minutes, sometimes 20, but patients are home usually within the hour and often back to work the next day. Certainly cramping can be experienced after the procedure, and everyone has different experiences, but most patients do very well. A rare
Yeah.
event with the ovary having a lot of cysts, it could twist on its blood supply, and that's called torsion. That, and I think maybe once in my career I've seen, but that would require an urgent surgery if severe to untwist the ovary. Rarely you would lose the ovary. So those are the basic risks of the process of IVF. You know, it leads us to the point, JJ, about what are the risks to the child and or medications long term for patients. Well, fortunately, the medications are safe. There's some suggestion of cancer of the ovary with fertility medication. Borderline tumors are typically treated rather successfully, but you know, women who don't conceive until after their 30s have higher risks of ovarian cancer. So, you know, you don't know if it's the medication or the infertility, as is the same case with birth defects. The baseline risk of birth defects in the general population in this country, the United States, is about 3 to 5%. That's just the way it is. And after IVF, it seems like it's a little bit higher. But you know, infertility patients have a slightly higher risk of birth defects than the general population. And that's even if they conceive naturally. So we can't say that definitively, but there are some circumstances, some epigenetic diseases that have an impact on offspring, but these are rare type of things. Fortunately, gosh, we're talking about IVF started in 1978 and we're in 2025. So
Wow.
if there was significant risks, they would have surfaced by now. But we are probably the most monitored specialty in all of medicine because we have continually reported our statistics by law to the CDC. And we have also have an organization called the Society for Assisted Reproductive Technology, which monitors cycles as well. And there's lots of medical data that's published to look at outcomes with our process. In the male factor, which we talked about briefly earlier, men with severe abnormalities in their sperm can transmit some what's called microdeletions or abnormalities in the Y chromosome that can pass on fertility, and there are a little higher rates of birth defect in those patients as well. Now, we don't know if it's due to the way that we fertilize the eggs. There's a procedure called ICSI. For all of you listeners who know about IVF, they know ICSI, ICSI, called intracytoplasmic sperm injection, where we take a single sperm and inject it into the egg. Well, in severe male factor cases, that procedure is employed. So is that procedure causing the potential risks? There may be, or is it the severe male factor that's causing these problems as well? So, but there's not a lot of absolutes in terms of the outcomes because there's so many factors involved when you look at pregnancy outcomes and birth defects or risks of disease. So,
Yeah. No, 100%. And I like the way you're talking about, success optimization and understand that because you combine deep clinical experience, academic leadership, also REI expertise. And like a lot of this stuff, you really should try to put yourself in the best overall health, right? When you're kind of getting yourself into something like IVF. And so a lot of these things you can be predisposed to certain genetics versus other people. We're all created differently. And that's something I've learned in kind of my journey in health the last 5 or 10 years. And I'd love to know from you, your thoughts on, do all women have the same odds for success? Or again, is that really individually based?
the terrific question again, JJ. Everyone is unique. You could do the exact same thing on 2 patients that apparently have the same prognosis and the same makeup, if you will, and one gets pregnant and one doesn't. Because there's so many factors involved, and we can't eliminate the sperm as a potential factor. I can't say definitively that infertility is inherited, but I agree with you that there are some genetics involved. To the point further, you could do the exact same thing on the same patient. The first cycle, she doesn't get pregnant. The second IVF cycle, she does. So it's the cohort of eggs that are going to be used that month. We can't eliminate stress as a role in this. There are many, many factors involved that we don't know, but we try to reduce and or eliminate those that we know are an impediment to the outcome.
Yeah, 100%. And again, it's so important to remind people of that every single person is different, right? And so you can't just say this person did X, so it's going to work for me over here. It's dangerous to generalize, and I think you make a lot of good points there. Also in your book, you discuss what I really love, which is with age and ovarian reserve in mind, personalizing success. I believe I heard a little bit about stimulation, embryo selection. Obviously, timing's important. Maybe talk a little bit about that because I found that part really interesting.
Well, the cookie cutter approach in medicine is never going to be successful because everyone is individualized, and that's the art of medicine. Yeah. That's a pun as well because assisted reproductive technology is art. So you individualize the care to the patient. It needs to also be a dialogue. Understanding the patient's needs. How much of a physical, emotional, and financial investment do they really want to put into this? There could be a 42-year-old who there will be clinics that say you have to do IVF. I don't tell a patient they have to do anything. My wife and I went through 10 years of infertility. It was suffocating, polarizing. isolating and overwhelming. We didn't know where to turn. So I get it. I think empathy is of paramount importance in this field. It's unfair to women to tell them to just relax. It's a burden and really a blame, because the woman interprets that as hearing, oh, so it's my fault, and if I just relaxed, I'd be able to have a child. And that's not what you want to say, and that's not what you want them to believe. But stress reduction can help outcome. It certainly helps the cycle. And I try to use an acronym with a word that's very powerful. I try to give them hope. But with hope, I use the acronym to have only positive energy, because you lose nothing from that. And those kind of imageries and mindfulness, those techniques of gratitude can only help you during your cycle. Because in the end, if God forbid it's not successful, you want to know that you did everything you could. And when that is the case, then you can be disappointed, but you don't have regret in terms of what you could have done differently. So I try to employ that on my patients, all of them, and because of the impact that this has on their lives.
Yeah, and 100% it will. Exactly as you said. When we talk about the patient journey, right? It's not always going to be perfect, but I think having a great mindset, staying positive throughout that patient journey as much as you can, even during the tough times. If something does happen later, regardless, not having those regrets is a really nice thing. And I think also we talk about costs, and helping navigate this entire process. You have an amazing structure and plan, but how do you structure care to help reduce? You talked a little bit about the emotional, but also there's financial stress, right, that comes across these different cycles and how long they last and these types of things, which, I guess couples only realize when they get into it, right? The ebbs and flows and the ups and downs.
The financial burden of infertility is an injustice. It's a disease. World Health Organization, the American Society for Reproductive Medicine, the AMA, these are organizations that have recognized it's a disease, yet not all insurance. It seems like it may be getting a little bit better, and there's some resources that patients can use, but it should be universal. It should be mandated. Everybody should have the right to be able to have a child and shouldn't have to beg, borrow, and steal, essentially, to be able to have the opportunity to have a child. That causes a discordance, that causes a demographic imbalance. That's not an equal access to care, and it's unfair.
Yeah, 100%. And I spoke to a few friends again who've been in this situation, and I think just obviously we talk about the emotional struggle, because even if IVF works, maybe you can talk about this as well. There could be multiple cycles of it, right? It's not like it works every time on the first time, or like you mentioned earlier, even if it does at all. But if it does, I had a friend who went through it, and emotionally she got up to a really excited point, and then it didn't work. And then you fall back down. And of course, there's the financial burden, as you said. And then she tries again. And then you're building yourself back up again. And so those expectations where you get excited, that's a tricky thing, right?
The cliche term is the emotional roller coaster. The expectations are very high, and the letdown is significant. I try to not be overly optimistic, but more realistic, and
Yeah.
using a cautious optimism. I discourage patients from going into it pessimistically, because I think that can play a role. I don't have good evidence to support that, but it certainly will impact your experience. And I try to encourage that this is the unique time in their life that they're going to go through something, and they're never going to forget this. So try, if you will, to enjoy the journey. It may not
Yeah.
occur, but definitely go through it in a way that it's not a dead end after. God willing, we have baby and we're good to go. But if not, sort of be prepared of what do I do now? It's not the end. My wife always says that the bend in the road is not the end of the road as long as you make the turn. So not having a dead end, and what do we do after that? And it breaks my heart if patients are putting their life savings, if you will, into a cycle, because where do they turn after that? So that's why I don't tell a patient you have to do IVF. We look at what they can do physically, emotionally, and financially, because you don't want to be able to pay for an IVF cycle and then have difficulty raising the child. So there's a lot to consider in this very unique time. But I certainly hope and pray that we're able to get improved coverage for patients to be able to go through this.
Yeah, and again, that's a great point because a previous episode we were talking with Joseph Pizzona about the healthcare system, and obviously certain areas need to be fixed. But it does kind of beg another question when you were talking about cycles for a lot of us that are going to be listening and watching to this episode with you with Dr. Mark Trolice. How long would a typical cycle last, or can I not even say an average? Maybe that's not how I would measure that, but what are your thoughts there?
Well, our society called SART, Society for Assisted Reproductive Technology, defines a cycle as an ovarian stimulation with an egg retrieval, creation of embryos, and then embryo transfer procedures until all of the embryos have been used. That's one cycle. But a patient thinks of a cycle as that 1 month for the egg retrieval. So that egg retrieval cycle is really about 2 weeks, stimulation and egg retrieval. If they have an embryo transfer, that usually occurs 3 to 5 days after the egg retrieval. And based on the individual circumstance, we can freeze the embryos. And then the following month, they have a 2-week buildup of their lining through different methods, either only hormones or ovulation induction. And then they have an embryo transfer, roughly about 6 days of the progesterone supplementation. Around less than 2 weeks later is the pregnancy test after the embryo transfer. So if they're going to do a fresh cycle with an egg retrieval, then we're talking about really within the month. If it's a frozen cycle, and that could become, if it's known that we're going to freeze all the embryos as opposed to just freezing the extra ones, then that would be at least 2 months or so, sometimes up to 3. And why do we just freeze embryos? Well, several reasons. One of them is that maybe the patient wants to batch embryos and try to get pregnant down the road because they're not ready to have a child now, for fertility preservation, or even for cancer or elective reasons. For cancer patients, of course, their chemotherapy and radiation could damage and put them into menopause, or certainly dramatically accelerate the loss of their eggs. So they come to us right away before their treatment, and we freeze their eggs or embryos. For patients that are going to overstimulate on the hormones, it is not in the best interest to do a fresh embryo transfer, because not only could they get sick from the overstimulation, but getting pregnant worsens all of that. So we hold off and freeze, waiting for them to get a period, and their risk is essentially gone by the time they are beginning the next cycle. Another reason would be to do embryo testing. That's called pre-implantation genetic testing. And in patients above age 38, that seems to improve outcome by removing some cells around the blastocyst embryo that allows us to analyze the chromosome makeup of that embryo by removing 5 to 10 cells. It's not 100%, it's not infallible, but there's about a 1 to 2% error because we don't take cells from that future fetus. We take it from the future placental cells. And sometimes those placental cells can be chaotic, and it doesn't necessarily match and synchronize with the future fetus cells. So all of those reasons can be used to freeze the embryos for a future embryo transfer. PGT is a can of worms conversation because it is being way, way, way overutilized for the wrong reasons. Patients may think it will improve outcome, and/or clinics feel that way, but it should really be used selectively because there's a cost involved, and using it selectively would reduce the numbers of embryos that get discarded that might end up having transferred successfully. There's other ways to do PGD, not just for chromosomes. Say a couple both are carriers of the same genetic mutation, like sickle cell or cystic fibrosis. We can screen the embryos to avoid that future baby from having the disease that can be terribly debilitating. So that's a valuable tool that's called pre-implantation genetic testing for monogenic disorders. So it's a robust technology, but it should be used for the right indications.
Yeah, no, 100%. And one thing I see online all the time, and again, this is why we started DocPod and shows like this with doc stars, with board certified doctors like yourself, is that we want to cut through a lot of the noise to find the signal, right? We want evidence-based, trusted content. I don't want to just go to Dr. Google or somewhere else and just pull up the information. I want to talk to someone like yourself. And I always see online, there's information about this person froze their eggs and it was for 10 years, 20 years, 30 years. I think even the other day I saw something about in early 90s. What are your thoughts and what's your knowledge tell you that in terms of what the experts are saying, how long, someone could freeze their eggs for? Or is that a stupid question?
No, not at all, JJ. A very intelligent question. And I have to plead the ignorance of no one knows. Right now, there is no expiration on eggs or embryos. As you can tell, that recent story was about 30 years of frozen embryos. Yep. We don't know the answer to that. So it remains to be seen.
Wow. And I guess we will only know the further we get deeper down and understand more, and eggs last longer, that sort of thing. But it's very, very interesting. So
let me just
I'd like to ask
something that interestingly, egg freezing for either cancer patients or elective, or we call social egg freezing, or planned oocyte cryopreservation. It's estimated that only about 11% of women have come back to use those eggs. So when patients come to me, they're in their early 30s and say, I'm worried about whether I can have a child, and I'm not ready to have a child now. I don't want to get too old. I want to freeze my eggs. I review all of that with them. It's not a guarantee. It is somewhat of a reproductive insurance policy, but you may never use them. And if you use them, it may not be successful. So I always try to educate the patient so that they can make an informed decision.
Why do you think that is 10 or 11 or 12%? What are your studies or, your observations tell you about that percentage, why it's so low?
Well, the reasons are not elucidated completely, but it's that patients either got pregnant naturally, and the earlier they egg freeze, the more likely they are going to get pregnant on their own, or they did not pursue pregnancy, or they have the other thing I was thinking about was that their partner did not want to use frozen eggs and wanted to keep on trying with natural methods.
Yeah. No, that makes sense. And when I talk to people, friends, family who have children, who are trying to have children, we've all heard over the years, a woman who tries to have children at a younger age versus a woman at an older age has greater probabilities of a successful having a baby and birthing, et cetera. Now we know that's been extended over the years, but what I'm hearing is that even with IVF, if you can freeze those eggs at an earlier stage, you probably have a higher probabilities of having a healthy birth versus at a later age. Would that be correct?
Absolutely. The younger a woman is, the higher the pregnancy rate. That's been known for years. It's unequivocal. Some women who come to me in their mid to upper 30s and haven't had a child, we talk about the options of IUI, intrauterine insemination, or IVF. And an argument to go right to IVF is if they want more than one child. Because by the time they have their child and wait a couple of years, they're going to be that much older to try again. But if they have embryos frozen, they are freezing the egg's age when they made those embryos. So it gives them an opportunity.
Yeah, which is great. Obviously we could talk for hours, but I would like to know if you had to kind of let all of us know listening or watching today, something we haven't talked about, but you feel is really, really important that someone would need to have a takeaway from this conversation today, what would it be?
Well, this is probably going to go more toward patients, but if general gynecologists are looking at this, I think it's important to adhere, as all of medicine, to be evidence-based. Fertility patients are at a terrible risk of exploitation. They are desperate. And they will take the word of really anyone in a position of leadership or knowledge, and that sometimes can be costly to them. Physicians' ethic is to avoid any conflict of interest, so revenue should not enter into any decision-making. IVF is the most successful option. It is the most aggressive option, but is also the most revenue-producing for all fertility clinics. It should be used with discretion, full informed consent about expectations for the patient. And I encourage also gynecologists to expedite the referral of an infertility patient to a subspecialist, because studies have shown the faster you refer to a subspecialist, the faster that she conceives, and the more likely that she will return to your practice for obstetrical care. The longer you take to refer, the less likely they're going to return, because then they get upset that it took that long. So
yeah,
our field is one of privilege. I am honored to be able to be involved in this aspect of a patient's care. Not only was I a patient, but I am convinced that this was my calling, and I am so grateful to be in this field.
That's amazing. And honestly, like you said, emotions are going to play into it. Revenue should never be revenue driven, as you mentioned. Emotions are always going to play into it. But I think you make a great point in saying, listen, we really need to try to follow the evidence, right? Follow the data as much as you can. And at the end of every show, we try to provide a clear signal. And what you just did is exactly that. And for me, what stood out today is really how much of IVF success depends on understanding not just procedures, but yourself, right? Because age matters, but it's not the whole story. And what you're doing, Dr. Trolice, is remind all of us that we're kind of rewriting what's possible, for hopeful parents by tailoring care, minimizing risks, and really focusing on what gives the best chance at a single healthy pregnancy, which I think is fantastic. So well done.
Thank you, JJ. My pleasure.
Yeah, special thank you to Dr. Mark Trolice of the IVF Center in Orlando, Florida. And to those watching and listening, thank you for joining us on DocStars. And as always, please subscribe. Very important, because this is something that allows us to continue talking to these incredibly important doctors like Dr. Trolice and healthcare leaders globally. Please like and continue following the DocPod channel, because health, it's everything.
Celebrating the world's best. This is DocPod's DocStars.